بداية أحب أشكر طبعاً دكتور إيهاب واللجنة المنظمة على الدعوة الكريمة في مكان جميل زي اللي احنا فيه. My topic somehow يعني will tackle حاجة احنا بنشوفها كتير في clinical practice, adrenal disorders and cardiovascular link. So when we think about adrenal gland and cardiovascular risk, what is going to strike our mind when we are going to think of this link will be adrenal hyperfunction. Whenever we are going to link cardiovascular disease to adrenal disorders, we are going to think about pheochromocytoma, hyperfunctioning of the adrenal medulla, primary hyperaldosteronism, and Cushing syndrome. However, I'd like to highlight that these disorders are not those only linked between adrenal gland and cardiovascular risk. There are other hidden diseases or disorders that may lead to various cardiovascular morbidities and mortalities, namely adrenal insufficiency and adrenal incidentaloma, including non-functional adenoma and mild autonomous Cushing syndrome secretion. So starting with pheochromocytomas, we all know that pheochromocytoma and paragangliomas are rare neuroendocrine chromaffin cell tumors that usually produce catecholamines, those arising from the adrenal gland, compromising most of the cases are pheochromocytoma. They are intra-adrenal paragangliomas. So what about the link between heart and catecholamines? So we all know the classical pheochromocytoma spells comprising the 5 Ps, and almost about 80 to 90% of cases having pheochromocytoma would be presented with hypertension. And it is true that pheochromocytoma is one of the endocrine causes of secondary hypertension, and about 1 to 5% of subjects suffering from hypertension will be attributed due to the presence of pheochromocytoma. And hypertension here may come in one of the 3 patterns, either sustained hypertension or paroxysmal attacks of hypertension, or hypertension at the baseline with superimposed attacks of hypertensive crisis. So what about the link between pheochromocytoma and cardiovascular disease? Is it only due to hypertension, or we do have another link? And here, this review, which was published in the year 2020, entails the cardiovascular manifestations and complications of pheochromocytoma and paragangliomas. So I can see here in literature many link occurs and observed between pheochromocytoma and cardiovascular disease. The link comes with acute coronary syndrome, recurrent heart failure, cardiomyopathy, ischemic stroke, thromboembolism. So we do have a tight link between pheochromocytoma and cardiovascular disease beyond the link due to hypertension. So we all know that the presentation of pheochromocytoma will be depending upon the catecholamine release. Either it is adrenal or noradrenaline, or in rare cases, dopamine-secreting pheochromocytomas. So classically, pheochromocytoma will lead to vasoconstriction or resultant hypertension, increased heart rate, increased stroke volume, increased cardiac output, and positive inotropic and chronotropic effect on the heart. So here, as you could see in this table, the published cases linking pheochromocytoma to cardiovascular disease with observed recurrent myocardial infarction, a special entity of cardiomyopathy known as broken heart syndrome due to stress-induced cardiomyopathy, embolic stroke, thromboembolism, recurrent heart failure, acute myocarditis have been observed and studied in cases of pheochromocytoma as well. So, a meta-analysis was conducted in May 2023 targeting left ventricular mechanics in patients with pheochromocytoma. This meta-analysis was conducted on 252 patients with paragangliomas and 187 controls, comprising around 6 studies. It showed that patients having pheochromocytoma, they do have early systolic as well as diastolic dysfunction observed in cases of pheochromocytoma. And here comes a very important question. Will these structure and functional abnormalities in the heart will be reversed after surgery for pheochromocytoma? Yes or no? So, a study was conducted last February in the year 2023, known as FEUCARD study. This study, they tried to observe the improvement in cardiovascular alteration, structure, and function in cases of pheochromocytoma following surgery. And here comes a very assuring data that structure and function abnormalities related to pheochromocytoma could be reversed after surgery. And this is very encouraging for us as endocrinologists to work along together with cardiologists in order to diagnose cases of pheochromocytoma and to implement sound therapeutic approach as early as possible in order to avoid long-term irreversible cardiovascular outcomes. Primary hyperaldosteronism, the most common endocrine cause of secondary hypertension. It is a group of disorders in which aldosterone production is inappropriate high for the sodium status. So, when aldosterone is high, it will lead to potassium and hydrogen excretion will result in hypokalemia and metabolic alkalosis, increased blood volume, increased cardiac output, and arterial hypertension. So, what we observe in cases of primary hyperaldosteronism, hypertension with low renin, hypokalemia, and metabolic alkalosis. And despite hypokalemia is observed in cases of primary hyperaldosteronism, eukalemia is not an exclusion of hyperaldosteronism. It has been observed in studies that only 1/3 of patients of primary hyperaldosteronism are presented with hypokalemia. So, as I mentioned before, that primary hyperaldosteronism is the most common cause of secondary hypertension due to endocrine disorder. This is why the Endocrine Society in the year 2016, it recommends that patients having hypertension, especially resistant hypertension, should be screened for primary hyperaldosteronism, as here hypertension could be cured with the cure of hyperaldosteronism. Hyperaldosteronism could be either due to bilateral adrenal hyperplasia or due to the presence of unilateral adrenocortical adenoma secreting excessive aldosterone. So what about cardiovascular risk in patients with primary aldosteronism? And here come this meta-analysis. It entails around 31 studies performed on around 4,500 patients with primary hyperaldosteronism compared to 52,000 patients with essential hypertension. What they found that there is increased risk of stroke, acute coronary syndrome, systolic and diastolic hypertension, left ventricular hypertrophy, and increased urinary potassium in cases of primary hyperaldosteronism. The effect of primary hyperaldosteronism on cardiovascular outcomes is independent with the link with the blood pressure changes. It has been observed that there is arterial wall fibrosis, myocardial fibrosis as well, vascular remodeling, cardiac hypertrophy, increased left ventricular mass, increased intimal medial thickness, accelerated arteriosclerosis, and endothelial dysfunction. So again, what about the cardiovascular outcome in patients with primary hyperaldosteronism following treatment, either medical or surgical? And here comes this study. It showed that the cardiovascular outcome could be partially reversed after treatment, either medical or surgical, and this encouraging us as well to go for sound treatment for cases of primary hyperaldosteronism to avoid irreversible cardiovascular changes. And when they tried to sort between adrenalectomy versus medical treatment, which of them superior in terms of better cardiovascular outcome, they found that this meta-analysis performed on around 6,000 patients with primary hyperaldosteronism. They found that adrenalectomy showed better outcome in terms of reduction of cardiovascular risk in patients with primary hyperaldosteronism versus medical treatment. And this gives us a conclusion that adrenalectomy is superior than medical treatment for the cure of cases of primary hyperaldosteronism and reduction of cardiovascular risk. And here comes the time to follow the guidelines of the Endocrine Society. Please screen your patients with a sound screening protocol for primary hyperaldosteronism to treat cases as early as possible to avoid irreversible changes. Cushing's syndrome, the most common functional adrenal adenoma, secreting adrenal adenoma. So Cushing's syndrome compromising a large group of signs and symptoms related to high exposure of the tissues to corticosteroids. The most common cause is iatrogenic. However, endogenous hypercortisolism is a rare endocrine disorder. So, as we all know, that Cushing's syndrome, due to various mechanisms, may lead to hypertension. So what about the other cardiovascular complications present in cases of Cushing's syndrome and its impact on cardiovascular morbidity and mortality? So here, some published cases linking cardiovascular disease in cases of Cushing's syndrome. It may lead to left ventricular hypertrophy, myocardial fibrosis, reduction of ejection fraction both in left and right ventricles, a rare form of dilated cardiomyopathy and myocardial fibrosis as well. And why do we think this link is apparent? Because there is a cluster of cardiovascular risk factors in cases of Cushing's syndrome, namely obesity, mainly visceral, impaired glucose tolerance ranging from prediabetes up to frank diabetes, dyslipidemia, increased risk of thromboembolic manifestation, the pro-inflammatory and pro-atherogenic milieu, together with endothelial dysfunction and hypercoagulability. And it is worth to mention that cardiovascular and metabolic risk factors are present in cases of subclinical Cushing. So now subclinical Cushing is replaced by the term of mild autonomous cortisol secreting adenomas, depending upon the result of 1 milligram dexamethasone suppression test. If it is less than 1.8, it excludes cortisol secretion. Between 1.8 to 5 Ug per deciliter, it may be possible autonomous cortisol secretion. More than 5, it is a definite autonomous cortisol secreting adenoma. So, subclinical Cushing syndrome is relevant to cardiovascular disease as well as overt Cushing syndrome cases. So, in cases of Cushing syndrome, there is structural and functional cardiovascular changes, and unfortunately, what was found that the cardiovascular risk is there even after apparent cure of Cushing syndrome. And what do you think about the proposed explanation why the cardiovascular risk is continuing despite that the excessive cortisol is abolished? Maybe due to the maintenance of some of the typical features of chronic hypercortisolism, mainly obesity, diabetes, dyslipidemia, resistance of hypertension, maybe the glucocorticoid replacement in cases of adrenal insufficiency following Cushing syndrome may be supraphysiological and due to the persistence of the pro-inflammatory and the pro-atherogenic milieu. So what about the other hidden link between adrenal gland and cardiovascular disease? Adrenal insufficiency may lead to increased cardiovascular risk. And what about the proposed mechanism? There are 3 proposed mechanisms linking adrenal insufficiency to cardiovascular disease. The adrenal insufficiency itself may lead to hypovolemia, dehydration, hypotension, and arrhythmias. Maybe overtreatment with glucocorticoids leading to iatrogenic Cushing syndrome. The hypercortisolism per se may lead to rise of pro-inflammatory markers, namely interleukin-6. So these are the 3 proposed mechanisms linking adrenal insufficiency to cardiovascular disease. And here comes a therapeutic dilemma. When we replace cases of adrenal insufficiency with glucocorticoids with the conventional therapy that we are having, either hydrocortisone or prednisolone, maybe they are under replacement that may lead to adrenal insufficiency with cardiovascular risk or over replacement with the iatrogenic Cushing, and here comes the problem on the conventional therapy. This is why they are trying to test either the once daily or the dual daily hydrocortisone extended release in order to overcome the problem with the conventional therapy of steroids. The last link comes with adrenal incidentalomas. So, what was observed in literature that the cardiometabolic outcomes are there in cases with adrenal incidentaloma, even with non-functional adenomas and mild cortisol excess. Because they observed that even in cases of non-functional adenoma, these adenoma may exhibit some glucocorticoid secretion that may lead to cardiovascular outcome. Ladies and gentlemen, let me give you my conclusion. To conclude, adrenal disorders are associated with various cardiovascular morbidity and mortality. Pheochromocytoma and primary hyperaldosteronism may lead to function and structural cardiac changes independent of blood pressure changes. Surgery may offer a good option for improvement of cardiac abnormalities in cases of pheochromocytoma. Treatment of primary hyperaldosteronism by medical treatment or surgery may lead to partial improvement of cardiovascular outcomes where evidence supports superiority of surgery in unilateral primary hyperaldosteronism. Cushing syndrome phenotype is associated with various cardiovascular risk factors. Persistent cardiovascular risk profile is observed in cases with apparent Cushing syndrome cure. Adrenal insufficiency and adrenal incidentuloma represent hidden link of adrenal disorders with cardiovascular events. Adrenal insufficiency with conventional therapy represent a therapeutic dilemma. And please remember that even non-functional adenoma and mild autonomous cortisol secretion both represent risk factors in terms of cardiovascular disease. And thank you.